laminoplasty zealot with us here today. And Dr. Shaffrey is going to talk to us about his favorite operation that he tells me he's been doing exactly the same way for the last 33 years.
I'm going to show that, although I drive the old beaten-down Ford Bronco, and unlike the Maybach that Alex does. So basically, these are my disclosures. Nothing is related to laminoplasty, and why, and we can argue about how much motion or you lose it a little bit. But the reason why OPLL grows is because the spine keeps on moving. It does have motion, and I'm going to show this. There's other things, post-laminectomy, instability, membrane formation, and whatnot, that favor laminoplasty. And I sort of put my money where my mouth was. This was a case from about 3 years ago, 55-year-old man, severe central cord syndrome. And everybody said, oh, man, you're such a laminoplast. We showed it at an indications conference, and we're treating him with hyperdynamic therapy and really resolving his blood pressure up. But he was profoundly neurologically compromised. And I said, you know something? You're right. So this was there. There was no fractures. There was no known instability. And I did this operation. He's a little bit kyphotic due to there, but he has made a complete 100% neurological recovery. And the fact is that even in this case, when you're treating myelopathy, I think laminoplasty has an advantage. I say this is the only operation I haven't changed. This is a paper from 1999 that I was an author in, me doing these cases. And this is how I did. This is a picture from 1994. This is a picture from 2024. The picture quality is a little bit better today. But the fact is I haven't changed the operation one iota. UVA is currently looking at, it got rejected by one thing because we didn't get patient-reported outcomes. What they were looking at was revision rates, and basically I had 371 cases that was done during my time at UVA. There were 4 reoperations of those 374 cases. That's, believe me, there's nothing else I do that has that. Why not? You don't, as Alex said, you don't want to have significant kyphosis. If you have instability, if you have significant large ventral pathology, and there may or may not be a higher incidence of neck pain. This should be the one take-home point for this. This is Zoe Gogolwala's randomized ventral versus dorsal trial. It was recently published in JAMA, looking at it. And what you see is 3 things. The complication rates for dorsal fusion was 29% in this large trial. The ventral complication rates were 47%, and the laminoplasty complication rates were 10.7, 11%. The results, as Alex mentioned, were generally the same. But this plot here shows the results of every single patient, and this is looking at changes of SF36. There was one laminoplasty that was made worse in all of those, and you see all the teal-colored arrows. That's the results of laminoplasty. The results of this were so good that the director of the NIH went and said, why isn't laminoplasty being done as the procedure of choice? Lower complications, this showed better results. This is a randomized trial. Why aren't people? And he said, because you get paid 1/3 as much doing laminoplasty. Until that changes, it's going to be hard to make a conversion. This is a systematic review looking at it, and what they found was that the JOA scores looking for myelopathy, the laminoplasty does a really good job from 9.5 to 13.5 on JOA scores. This showed for looking at over 2,500 patients, showed that there really wasn't this significant increase in kyphosis that Alex described. This was another study, this is a continuation of the study, showed that the average VAS pain score, neck pain score was 2.78, showing these people all don't have horrible neck pain after it. This shows another study looking at it, showing in fact that most people's neck pain improved with laminoplasty. So what my belief is that, for myelopathy, myeloradiculopathy, 3 or more levels with a straight or lordotic spine, I think laminoplasty is the best option. Thank you.
Thanks, Chris.